So welcome to another episode of Blood Matters, a podcast for nurses. Thank you all for joining today. We have a really exciting pod again. This time our topic is going to be based on late effects screening and guidance. As you may know, the new late effects screening guidance was published earlier this year. And so we're going to find out a little bit about how that was developed. We're going to hear from one of the lead authors around the concept and how that was all worked, and a bit of an overview about what's included, what's new in the new guidelines. And then we're also going to hear from Trude, who will talk about her experience of working in a late effects clinic. So it's going to be really exciting and really interesting topic that's very close to my heart because I work in the late effects setting predominantly. Hilda, what do you think?
Yeah, what you said, it is an exciting topic, and we have also two exciting guests today with us. I think they can tell us everything from their own experience. One from the guidance perspective, and Trude mainly from her experience as a clinical nurse specialist. And yeah, I think it's wonderful to hear from them their experiences and how they think about this topic. Looking forward to it.
It's going to be great. So without further ado, shall we welcome our guests then?
Yeah, that's great.
So now we're joined by our two guests, Rachel Phelan and Trude Minnee. I'm going to bring Rachel in first to the conversation. Rachel, can you please introduce yourself? Tell us a little bit about what you do.
Sure, I'm happy to. So I am an associate professor of pediatrics at the Medical College of Wisconsin, in Wisconsin in the United States. And I specialize in cellular therapy and stem cell transplantation in that population. So I treat patients with both malignant and non-malignant conditions that require that type of therapy. And my research and clinical interest also lies in survivorship and surveillance and prevention of long-term side effects or late effects in this population. And in that role, I am the medical director of our survivorship program, which is called the Next Steps program here at our children's hospital, which is called Children's Wisconsin. And I also spend some of my time at CIBMTR, where I'm one of the scientific directors of the Morbidity, Recovery, and Survivorship Working Committee. So I focus my research on our CIBMTR database and how we can use that to, again, improve quality of life for these long-term survivors, use our data to identify gaps and places where we can improve outcomes for these patients who are long-term survivors. And in that role, I work with a lot of people over at EBMT. So I'm happy to join you all here today.
Gosh, that sounds also super interesting, Rachel. And the work with CIBMTR, that must be kind of fascinating to get to the back of what's happening with people. So kind of looking at that big data and seeing how that lands and looking at the recovery and issues that people experience. I'm going to hand over to Hilda now for your next question.
Thank you, Michelle. Yeah, Rachel, we will continue with the next question, and that is the term late effects is used in a number of different specialities. So it would be good to start with a definition of this term, specified for the transplant and cell therapy setting. Please, could you describe this for the listeners?
Sure, of course. So yes, late effects is a bit of a generic term, isn't it? We could use it in a lot of different healthcare settings and specialties and pediatric and adult. But really, in general, it means when a patient develops a specific health problem or health condition in the months or years after treatment has ended. So in this specific circumstance, in the months or years after a patient has received a stem cell transplant or has received some type of cellular therapy. So we do separate it out a bit from acute side effects, which we are all very familiar with as well. So when a patient is undergoing a transplant or cellular therapy, they oftentimes will have side effects related to the chemotherapy they receive or radiation they receive, et cetera, in the days after they've received it or while they're actively receiving it. But in this circumstance, we're talking about things that occur much, much later, but are still likely related to receiving that particular treatment. And the timing of those, quote unquote, late effects is really variable, and it depends on which specific side effect or condition we're talking about. And it also depends a lot on risk factors of the patient themselves. So it's extremely variable. So if a patient received treatment when they were an infant versus if they were 70 years old, that can impact their risk of developing one of these conditions. Also, what their underlying condition is, what their genetics are, what their lifestyle factors are, where they live, all of those play into the risk of developing these long-term conditions. So it's definitely not a one-size-fits-all for these patients, which is why monitoring for these are really critical.
Thank you. This is a clear description, and that's good to work from then on to the next question, which is for you, Michelle.
Thanks very much. Yeah, I was thinking about pediatric late effects and adult late effects, and you really illustrated that really nicely, Rachel. Thank you very much. You recently collaborated on the late effects screening and management guidelines, the new paper which was published earlier in 2024. It was obviously a while since we had the previous iteration of those guidelines, which really have been a cornerstone of late effects care for a lot of centres globally. Can you tell us some of the key differences between the 2012 Majhail guidelines and the new 2024 guidelines? And a follow-on question for that would be if you had any guidance on the implementation of those in the clinic. So how do people start to use them, really?
Yes, of course. Yeah, great. Thank you, Michelle. Yes, I'm happy to talk about that. So as you pointed out, it had been a while since these guidelines were updated, about a decade, actually. And one of the reasons why I was drawn to this specialty when I was choosing what to go into in medicine is because of how quickly things change and how exciting it is, right? So we are continually having new treatment options and more individualized treatment options for these patients. And so that also means they're at risk for the potential of different late effects or side effects of these treatments. And so we do need to make sure that we are updating our guidelines and including new therapies that patients are receiving. So we were excited to put this very extensive document together, and hopefully all of you that are listening are aware of this document or now are, because it is a very extensive and very comprehensive document, and we are really hoping that you are able to use this in your clinical practice. Some of the things that I will point out that have changed compared to the prior guideline from 2012 is there are a couple different new sections. So one is focused on hematopoietic complications. So things such as thrombotic events, how often we should check CBCs, those types of guidance. So that is a nice addition. We also have continued to learn more over the last decade about the importance of psychosocial adjustment and cognitive dysfunction and quality of life, and how important monitoring for that is in this patient population. So we definitely expanded on that section. We also are all familiar with changes that have occurred in the last decade in terms of infectious diseases, in particular COVID. And so we wanted to make sure that we updated our vaccine guidance and made that more comprehensive and up to date. In expanding on the importance of quality of life and going back to kind of that psychosocial aspect of things, we also included some return to work and return to school guidelines for patients and families and providers, which we hope will be helpful for you all. There were a few, and I want to make sure to point this out, updates to subsequent malignant neoplasm screenings as well. The most notable being that for colorectal cancer screening, and that occurring at a younger age and potentially more frequently for your patients. So I recommend that you make a note of that particular section. And then as we continue to learn more about other rare diseases and the addition of things such as gene therapy for some of those conditions, we wanted to make sure to call out, things that are needed for patients who have underlying hemoglobinopathies or metabolic disorders, et cetera. So we do have additional tables and guidance for what we deemed special populations, where you may want to make note of some, specific considerations for those groups. And then as Michelle and I both pointed out earlier, it's interesting to always think about the age at which patients receive their treatment and how that can impact their long-term care. So in addition, we do call out ways that we should be monitoring those that received transplant or cellular therapies when they were infants versus adolescents and young adults versus older adults, and how that may impact the treatment plans for all of those patients. So how to implement this document in your clinic is also really important. So as I mentioned, a very comprehensive guideline we tried to put together for all of you to use. And we also recognize that we don't anticipate anybody will have time to read the entire guideline in between patients. So we did make sure to include many different tables for each specific, potential complication or group of complications. So there's a number of different sections. And we also included supplemental tables that are very, quite easy to read, and also point out if the patient received radiation, if they had graft versus host disease or currently have graft versus host disease, how that may impact screening or their risk for developing a late effect, et cetera. So really what I recommend and what we have done in our clinic is to print out the tables, because I think that's a lot more digestible when you're actively seeing patients. And what we have done in our practice too is to make sure that as a group, both those who specialize in late effects and those who do not are aware of the document, and we have taken some time to point out some of the highlights to the group. One particular screening recommendation that I want to point out that impacts those that not only take care of patients long-term, but also short-term, is something like the frequency of pulmonary function testing post-transplant. So that's recommended actually quite frequently in the first year post-transplant. So those that are focused on seeing patients in a survivorship clinic, we'll be seeing them when they're getting that less frequently, but we want to make sure that those clinicians that take care of patients who are in more of the active phase of treatment are also aware of these recommendations, because it may impact them. So those are some thoughts that I have, but happy to follow up on any of that as well.
That's amazing. Thank you, Rachel. Thank you. Over to you, Hilda.
Yeah, thank you, Michelle, and thank you for your comprehensive answer, Rachel. And it's so good that the parts are included on the rare diseases, and the non-malignant part is also the developing gene therapy. So that's great to hear. The next question is that patients can find the term and concept late effects quite challenging. And how do you make this feel less threatening for your patients?
Yeah,
and maybe you can differ between the age groups a little bit.
Yes, definitely. That's a really great question. And one of the things that I do, and I think, I've taught my partners well enough as well, when talking about late effects constantly, because that's what I do, is it's important to talk about late effects even from the beginning, right? So when I meet with a patient prior to even undergoing a transplant, I focus on not only you're going to have nausea, you're going to have mucositis, you're going to be tired, all the things that we anticipate in the acute period. But I also make sure to start to note some of the potential long-term side effects that may be impacted. Some of the things we can act on even before the transplant, such as if the patient wants to undergo something like fertility preservation, right? It's important to start talking about that from the beginning. But some of these things we can't do anything about, but it's important for the patient to know that they're at risk for it in the months and years to come. And I don't at all anticipate, none of us do, that the patient's going to remember all of those things that I talked to them about, right? Because it's just so much information and it's so overwhelming. But I do think that repetition is a really important part of what we do because of all of the things that the patient will go through and what they're at risk for. So just starting to mention those things at the beginning is really critical. One of the other things that we have implemented in our survivorship practice, and we've done this a bit for our transplant and cellular therapy patients, but we've done it even more consistently for our patients who have just undergone cancer treatment. So this, because I take care of those patients as well in my clinic, is when they're coming off therapy, we meet with them as a survivorship team. So just the survivorship team alone. And we start talking to them about our clinic and what we have available and what we'll be doing and screening for and how that's different from undergoing the active treatment that they've gotten so used to over time. And just what to anticipate in the survivorship clinic. And we start going through their treatment summary and surveillance plan, because once again, repetition is key. So we start doing that even as they're coming off of active therapy. And even in our transplant and cellular therapy patients, we start incorporating more of that education, into the earlier phases post-treatment so that they start hearing it more. And then we do eventually transition all of our patients to our dedicated survivorship clinic. And then at that time, again, it's, a third or fourth time that they're hearing this information. And we found that as we've been incorporating more consistently this early education about late effects, that when they do make that transition over to our survivorship program, it's more like, yeah, I've heard that before. Thanks for reminding me. But it's something that I'm not as intimidated by because you've told me about this many times and I'm more mentally prepared for it instead of being surprised by it. And then also meeting the patient where they're at, right? I mean, sometimes patients want to hear numbers, like this is the percentage chance of me developing breast cancer or skin cancer or, hypothyroidism or whatever. But some patients just want to hear that that's a particular risk factor, but we are going to help to make sure that they get that screening done. So every patient's going to have specific needs, and getting to know them over the years will help you to meet those needs at, where they're ready. So
that's wonderful. A lot of repetition and also a good transition keywords. Thank you. Over to you, Michelle.
Thanks. Yeah, it's really, really important to identify where those transitions happen, isn't it, for the patients? And it's not always in the same spot, I guess, for every single patient. So again, that can be a fairly dynamic thing. It's not always a year for every single patient, for example. So hitting that at the right time is really important. Rachel, what's the most preventable late effect in your experience? So we want to be able to manage late effects. We want to be able to screen for them, but we always also want to be able to prevent them from happening. So in your experience, what's the most preventable?
Yeah, that's a really tough question. It's hard, and there's so many to think about, right? I do think that there's a lot of room that we have in the area. Well, first of all, we talk about cancer screening and making sure that that gets done. I think that that's something we can do, although, developing a subsequent neoplasm isn't necessarily always preventable. Detecting it early is possible if we follow our screening guidelines. But when thinking about things that are, truly preventable, I think that one of the things that we could, do a better job at working with our patients with is related to metabolic syndrome. So in the United States and in other areas of the world, there's a lot of, increasing incidence and prevalence of obesity, and, poor nutrition and exercise practices and things like that. And, when a patient undergoes transplant and are actively undergoing transplant, it's not a time when they're going to want to think about exercising or, eating healthy foods when they can't taste food or they're nauseous and, only certain things are providing them with nutrition needs. But as I talk to my patients a lot about, as we're coming out of that active and acute phase and we're starting to get more energy and we're starting to feel better, then that's when we really try to bring in our nutritionists. So we have registered dietitians that are part of our clinic, and they really play a very critical role. And I think there's a lot that we can do with physical therapy and early rehab. And I know there's a lot of research in this, and how can we get the patients moving even when they're in the hospital, right? When they're still hospitalized, and get them realizing what they're still capable of, at certain time points, even in the acute transplant period. And again, even talking about optimizing these things before transplant and cellular therapy, I think there's a role for that as well, and talking about that early and what we can do. So metabolic syndrome, which includes, high blood pressure, obesity, diabetes, insulin resistance, et cetera. I think that is a focus area for us to continue to research and determine how we can get patients, eating healthy, moving more in the both acute and long-term periods post-transplant. And it has so many downstream effects, right? Risk for stroke, risk for cardiovascular events, risk for developing, full-on diabetes. And so I think that this is probably the area where I think we can really focus on prevention.
Thanks, Rachel. Yeah, and those issues sometimes are happening on the back of an already fragile system, aren't they? So, it makes the impact so much greater. I'm going to hand over to Hilda now for your final question.
Thank you. Final question for you, Rachel, in this round. Why is or should survivorship be important to healthcare professionals?
Yeah. So hopefully I pointed out a lot of reasons already in what I've talked about. Transplant and cellular therapy and late effects, when we talk about that, the late effects that can occur across the whole body. So, you're going kind of back to, I think, the second question you asked me, which is the definition of late effects and how that that definition can be important to all different specialties, right? This is true. A cardiologist, you can have a late effect from having hypertension, or from, when we talk about those types of things, cardiomyopathy, et cetera. But when we're talking about our area, we really, and you'll see this in the guidelines, have to think about everything, literally everything, right? And because those late effects can occur everywhere. And so it really is important to all different subspecialists. We work so closely with the pulmonologists, the cardiologists, the dermatologists, the endocrinologists, right? I have my list, my phone book in my head of who I call when one of my patients needs them. So it's really important that we continue to work with all of our subspecialists to make sure that they are aware of the late effects and, the emerging therapies and how the risks for late effects change with new therapies, et cetera. And so again, across the spectrum, subspecialists, I think it's important for them to know about what our patients are at risk for. But potentially even more importantly, our general practitioners, it's really critical that they are aware of what our patients are at risk for and what screening they require. Going back to transitions and making sure that those transitions occur successfully. A lot of our patients in the years post-transplant eventually will transition back to their general practitioner. And they see us less and less. We know that happens. And our patients, unfortunately, there's a significant number of them that are lost to follow-up care with the transplant or cell therapy center. So we do need to make sure that we increase awareness in the general practitioner community of what these patients are at risk for. and they're busy and they see a lot of patients. And so I always feel like it's one of my jobs to make it as easy as possible for them. So making sure that we are sending summaries, if we can, to the general practitioner of what's most critical and important for them to know, making sure that we're educating our patients as much as we can and providing them treatment summaries so that they then can pass it on to their general practitioner, whatever subspecialist they see, is really of critical importance. So obviously, I'm a little biased, but I do think that this area is very important, and very important not just to us that are listening to this podcast that are, part of the transplant and cell therapy community, but really everyone that takes care of patients, because as rare as some of these conditions are, it's very likely that almost every general practitioner may have one or two patients that have undergone this type of treatment. So important for them to know.
Yeah, very important. Thank you so much, Rachel. We will come back to you later in this session, but now we'll bring in Trude Minnee. I'm happy to have you here, Trude. Welcome. And
thank you for the invitation.
Thank you very well. Welcome. Can you please tell us a little bit about yourself and your experience as a clinical nurse specialist working in the late effect clinic?
Yes, of course. Well, my name is Trude Minnee. I'm a wife and a mother of 2 teenage daughters. And I love to spend time with them, and I love to spend time with my family. I train and coach my daughter's field hockey team, and I play a little bit of field hockey myself. And as a nurse, and my experience in the late effects started in 2003. I started as a nurse at the pediatric stem cell transplant department of the Leiden University Medical Center in Netherlands. And there I specialized in the pediatrics, hematology, and quality of care. And I'm also part of our children's comfort team. And in 2020, I started at the pediatric stem cell transplantation outpatient clinic with the specialization of the late effects of the pediatric stem cell transplantations. And first as a clinical nurse specialist in training, and now as a full clinical nurse specialist. And a little side note, we only treat non-malignant diseases. So there's a little bit of differences between the diagnoses.
A very specific group. Thank you, Trude. Glad that you will join us today. Back to you, Michelle, for the next question.
Thanks. Hi, Trude. It's lovely to hear from you and lovely to have you on the podcast. So there are a few different approaches, I think, to how we organise our late effects clinics. So some people run them as physician-led, some as nurse-led, some have joint approaches, some clinics are multi-specialist. Can you explain a little bit about the model that you have in your centre? Who's involved and why is that important?
Yes, of course. Well, I think in our clinic we use mainly a joint approach, the pediatric hematologist and me as a clinical nurse specialist. And I think it's important because in this way we combine and merge our skills, the doctor skills and the skills of the nurse, to improve our quality of care for the patients. And well, I know that the patient tells different things to the nurse than to the doctor. And with the nurse, the patient feels more room to talk about non-medical issues and especially the psychosocial ones. Well, and I think that is of added value to complete the patient's picture of how he's doing. And we also work together with subspecialists, so the endocrinologist and other subspecialists. But mainly we work together, the pediatric hematologist and me.
Thank you, Trude. So do you sit together in the clinic, or do you see the patients separately, or you work with one patient together?
Well, we see them separately. So I'll speak to the patient first, and then the hematologist see these patients also. So we work together, but not in the same room. Okay. So the patient can talk about me for other things than to the doctor.
Okay. And so what is it that the doctor does in your clinic, and what is it that you as a CNS do? So what's the role?
Difference? What's the role? Yeah. Well, I think I do a lot. I talk a lot with the patients. That's my start. I start with how the patient is doing. and are there any problems or any issues they want to talk about. And the doctor will see them later on, and we both do physical examination. So that's, well, we there's no difference between our roles, but we choose to see them differently, because I know they speak, they tell different things to me than to the doctor. So I think that's the most important thing in our role, that we complete the picture.
Yeah, and that's so important, Trude.
Yeah.
So very important.
Yes, I think so.
Thank you very much. I'm going to hand over to Hilda.
Thank you. And Trude, you have quite a bit of experience in value-based healthcare in the Lady Facts Clinic. Can you tell us a little bit about this and how patients experience this clinic?
Yes, I have, and I can talk about it for hours, but no worry, I won't. Well, it started 4 years ago because we wanted to improve our care pathway. So we started improvement projects, and to do so, we used the principles of value-based healthcare, and we combined this project with a PhD study. So we involved all disciplines who are involved in this care pathway, as well as the patients and their parents, of course, to set up a patient journey. So in this way, the points of improvement became visible for all of us, and we were able to work on this together. And I think the involvement of the patient in this project is really unique and of great importance, because who knows better than the patient itself where the areas of improvement lie. So there are great value in our projects, and they feel really involved and really a part of our process and our projects. And they also say, okay, well, tell me about the progress and about the results of the project and the study, and tell me more about the answers and about how we're standing and what we're doing. So they really feel involved in this.
Thank you. And I think you will you can tell a lot about it, as you said. And I was just wondering, what do you also implement? Like, did you implement proms and prems, or how
Yes.
did you do that?
The proms we implemented indeed. So we ask the patients to fill in questionnaires, and so we take the prompts in our process of care pathway. It's really it's a standard thing in our care pathway. So
It's embedded.
Yes, thank you.
Yeah, thank you.
Thanks, Trude. Sorry.
No, next question for you, Michelle.
Trude, can you talk a little bit about the areas of late effects care that you think could be improved, the things that we could do better?
Yeah, sure. I think we can improve our psychosocial help. This treatment is really highly intensive, not only for the patients, but for the entire system around the patients. And during the inpatient stay, there's a lot of psychosocial help. There are psychologists or any other help for the parents and the patients, but it stops when they're going home. But during this phase, there's also a need of psychosocial help for processing what happens, but also for how do we proceed. And there are many issues remain. So I think that's really important to improve our psychosocial help after when the patient's going home. But if you look at the medical late effects, I think also the endocrinological issues are the highest of impacts. For example, the reduce of growth or the gonadal dysfunction. And so I think by doing more research into this, I hope we can adjust the treatments. So there are hopefully less late effects in this area.
Thanks, Trude. And for the psychosocial help, is that kind of an issue with resource, to have people who can work with patients after discharge, or is it a shortage of psychologists or nurses, or?
I think it's all.
How would you fix it?
Yeah, well, that's a good question, because we want to fix it, and I think it's by using our project of the principles of value-based healthcare, combine it with a PhD study. You can, I hope you can improve this, and you can make it work and make sure that the psychosocial help is embedded in our care pathway early on and later on. So just during the whole care pathway. But you also need research, and you need money, and you need persons. Yeah.
Thank you, Trude. Thank you. We're on to our quickfire round already. So thank you both for sharing your insights so far. It's been incredibly interesting for me, and I'm sure for all the people who are listening and have tuned in. I'm going to hand over to Hilda for the first question.
Yeah, we have a quick fire round where we ask you both questions, and we will start with you, Rachel, and then we can follow up with Trude for the same question. What is our greatest approach against the development of late effects, and why?
Yeah, so against the development of late effects. So I think that really one of our greatest approaches that I've talked about already is education of the patients, the parents, the caregivers, the healthcare providers, because, as I talked about earlier, not every late effect, unfortunately, is preventable with what we have right now and the treatments that we give patients. But the identification and surveillance of them is critical, because oftentimes, even if it's not preventable, if we diagnose it and treat it early, then the outcome is significantly improved. So making sure that everybody's aware of what these patients are at risk for is just extremely important. So education, making it digestible, again, hopefully these tables that we put out for all of you makes it more digestible for us who are seeing these patients in the clinic. But then also the treatment summaries, what we give to the patients, what we give to the other healthcare providers. Just really important strategy when addressing these late effects in patients.
Thank you, Rachel. And for you, Trude, what do you think is the greatest approach or strategy?
Well, I agree with Rachel, but I also think that what I told early on, I think the use of study, so by doing more research into the late effects, we can hopefully adjust the treatments. So I hope there are, the development of late effects are increased, but also the annual check of the patients on the development of late effects, because if you discover a late effect early on, you can treat it early on. And I think that's really a good thing. And also discuss the importance of a good and healthy lifestyle. But you already said so, Rachel, yourself. So I totally agree with it.
Yeah. I mean, I also agree with your approach to patient-reported outcomes as well, that you mentioned earlier. We're trying to incorporate those into our clinic. Again, finding out what is important to the patient is critical in so many ways, and also more motivating to the patient in terms of change, right? Because if we can identify what's truly on their mind and is what's bothering them the most, what's most important to them, meeting them where they're at is a really good agent for change, way that we can motivate people to find out what's most important, what we can do to impact that. So
yeah, I totally agree. We before our consultation, we ask the patients and the parents to complete a digital questionnaire, and those are mainly questions about experiences of the quality of life. So, for example, how are they sleeping, or how is the relationship with friends? And then during the consultation, we discuss those questionnaires with the patients, and of course, depending on the age. If you discuss it only with the patient or with the patient and the parents. And I think, it's really important. For example, last month, I discussed the questionnaires with a teenage girl, and I already had seen that she was not doing so well. So we discussed the answers, and she told me that because she completed the questionnaires, she felt there was room to talk about it. And she said, well, I would never have told you this if it wasn't for the questionnaires. And now she's receiving psychological help. And without the prompts, I think we were not able to help her in this way. So I think it's really important.
Yeah, that's a great example. Thank you so much.
Yeah, the prompts can be really useful in validating people's concerns. So if it says this on the paper, and this is what I'm thinking, then somebody else must have also felt like this, or it must be a valuable or important idea or problem that I'm having. And Rachel, you referred a little earlier to people being lost to follow up, and I think we all experience that as an issue to one extent or another. What strategies do you think would be helpful to ensure that patients are still able to attend a late effects service?
Yeah, that's a great question. I think it's a stretch for us to ever say that anything good came out of the COVID pandemic, but the one thing that we maybe can identify is just the access to telemedicine and virtual care. That's so much easier to do now. I think it's incorporated probably into all of our clinics in some form or another, and patients and families have kind of been forced to try it maybe at least once, whereas that may not have been top of mind previously. So I do think that that is something that should continue to be investigated and incorporated and utilized in our patient care in some form or another, especially for those patients who do move far away or go from, childhood to adolescence to adult care. Is there some way we can incorporate virtual visits into their ongoing care or transitions? So that is one area that I think we can continue to explore and research in terms of how that can improve loss to follow-up rates.
Thank you. And over to you, Trude.
Well, our loss to follow-up rate is 0 because in the pediatric, I have to say, because in the adult follow-up program there is loss to follow-up. But yeah, we call the patients 1 or 2 weeks before the consultation to make sure they are coming, and I think it's important to keep in touch with the patient and to get a bond with them and try to keep the bond with the patient. But again, our country isn't that big, so it's easy for them to come. It's more easy for them to come to us. So I think to keep in touch with them and keep the bond, then they will come.
Thank you. Hand over to Hilda now. Thank you.
Thank you. What piece of information you know now would you want your team to incorporate into late effects clinic? Rachel, first to you.
Yeah, I think one thing that I've learned over the years of doing this is the importance of personalization of care. So, maybe when I first started and was a little more naive, it's like, oh, I can just follow this guideline, right? And it'll all be fine. And the guidelines are important, but they're a guideline, and each patient really, their care does need to be personalized. I mentioned a little bit earlier, the risk factors for late effects are really complex. So we can look at a table, but there's no way a table can include exactly what age the patient was, what their social support is, where they live, if they smoke. There's so many different things that play into the risk factors for late effects development. So one takeaway that I've learned over the years is just the care for each patient really does need to be personalized, and we can use guidelines to help us develop a long-term care plan, but we also need to use our relationship and long-term care of these patients when we are really making those treatment plans and really individualize them.
I totally agree.
Thank you. And yeah, Trude, to you, what are your thoughts?
Well, I totally agree with Rachel. And as I said early on, I think really that the way we use our project by using the value-based healthcare principles combined with the PhD study and a joint approach can really helping to incorporate our team into the late effect clinics. So I think that's a good thing.
Thank you so much, Trude. Over to you, Michelle, with the last question in this round.
Thank you. Final question before we close. So do you have one phrase, Rachel, to summarize the importance of late effect screening and management?
Sure. Yeah. I mean, I may have stolen this phrase at some point from somebody. So if somebody's listening and they're like, hey, that's my phrase, feel free to email me, and then I'll make sure to acknowledge you. But I think one phrase that's stuck with me, and maybe I've modified it over the years, is just that care doesn't stop with cure. So, of course, we all celebrate the end of cancer treatment, the end of the acute transplant period, the, cure of somebody's quote unquote sickle cell disease. But, we know, and what we've talked about this entire podcast is that these conditions and these side effects of treatment or late effects of treatment can occur months, years, decades after the patient have received treatment. So we can all celebrate, which it definitely is something to celebrate, and I celebrate with my patients the cure of their underlying disease, but we do still need to continue to care for them for the rest of their lives, because what their needs are going to be different from the general population. So, and not only care, but also research has to continue in this area as well, which was mentioned earlier too. Things will continue to change. The treatments we offer these patients continue to change. We have CAR T cells, we have gene therapy, we have targeted drugs that we give these patients, and a lot is still unknown about what the risk and what the particular late effects are for those particular treatments. So we need to continue to research late effects forever, really. And also, I'm really excited about personalized late effects and what may come from research in that area as well. Are we able to find particular genetic modifications that a patient may have that increase their risk of developing a particular late effect? I think there's just so many areas of research within survivorship that are very exciting. And so, yeah, care doesn't stop with cure. That's what I'm going to use.
Brilliant. So if I use that, I may credit you with it.
Yeah, and then whoever I'm taking that from somewhere.
And Trude, for you, a phrase to summarize the importance of late effects screening and care.
Yes. No, I love your phrase, Rachel. So I'm keeping it also. Sorry, but I write down a better outcome in all domains. So I hope that not only the medical domains, but also the non-medical domains, a better outcome for the patient. And when one result of our study is that the patients are doing well, good. Their quality of life is good. So we're saying what doesn't kill you makes you stronger. And I think that's a good one for our patients.
Mm-hmm.
Thank you very much. So that comes to the end, I'm afraid. We're out of questions, but we leave the podcast knowing a heck of a lot more about late effects screening and management and late effects care than we did at the beginning. So I just want to take this opportunity to thank you both very much for joining us.
Yeah, thank you so much.
Thank you.
We had really a great conversation with these guests. Michelle, what do you think?
Yeah, I thought it was brilliant. I think we're very lucky to have been able to welcome both Rachel and Trude and have them share their experience. So what are your highlights, Hilda?
Yeah, it was lovely to hear how the guideline is expanded with all those different topics and aspects. I think that's quite super important. And what I learned from both is that psychosocial care is so important, and to build and to keep a bond with the patient and build a relationship with them in order to keep them coming to your clinic and also to keep them healthy. I think that's what the main thing I remembered from this podcast and will bring with me to the clinics.
Yeah, I think the importance of using the guidelines as a vehicle, but in conjunction with patient-reported tools to be able to offer that personalised care. It's not one size fits all. I loved the closing phrases that both Rachel and Trude offered us. So care doesn't stop with cure, and a better outcome in all domains. Love that.
Yeah, it was really lovely, and I think it's also it was also very nicely outlined that both the roles of physicians and nurses are important in these late effect clinics. So I think that's a good message to our listeners. So I hope everyone will have enjoyed listening to this podcast. And we thank you for listening. Thank you, Michelle, for being my wonderful co-host today. And thank you for the background team for their great job. And have a nice evening or rest of the day.
Thank you.